Okay, thank you. Can we progress? Yeah. This was a bilateral buphthalmic baby, I can say, with vitreous hemorrhage and tractional retinal detachment. As you see, he was 10 months old. It was a term baby with 3,000 grams birth weight. But the eyes were large, starting from the birth, as the history says. And he was using Azopt and Zalatan, which was started in another clinic. And he had been accepted as inoperable. And in other clinics, nobody wanted to operate him. And there was no family history. And this was the appearance of the eyes. As you see, it was covering the whole opening of the interpalpebral area. So there was no fixation and following of the light at the beginning. And you see the anterior segment here. Both were buphthalmic. The cornea was 15 to 16 in the right eye millimeter, and in the left eye it was 16 to 17 millimeters. Intraocular pressures were in the 13s to 14s, 30 to 40, and cornea was cloudy in both eyes, and there was total iridocorneal apposition in both eyes. There was iris neovascularization with pupillary membrane causing leukocoria. And in ultrasonography, we could see some vitreous opacities associated with some tractional retinal detachments. So at this point, I was not so sure about the diagnosis, and I hesitated to operate him or not, but I thought that I wouldn't lose anything because there was no fix and follow at the beginning, so I decided to operate. And this was the first eye to start with. I just started with a spatula to separate the iris from the cornea. As you see here, I used some viscoelastics to separate the iridocorneal adhesion, and it worked, thanks God, because I was not so sure about that. And after separation of the iridocorneal adhesions, the cornea was a bit better. So I was hesitating if I can see the retina or not after this separation. Then we did some pupilloplasty, although there was some iris problems, neovascularization problems. Then we were surprised that retina was not so bad, as you see here. There were, of course, membranes, some hemorrhages, vitreous hemorrhages, but I could see that we can separate most of the tractions, most of the membranes from the retina. We have enough view, at least, to see these membranes, although it was a bit hazy, but not too bad, as you see here. Then after cleaning the membranes as much as possible, I mean with that cornea, then I could see that there was peripheral avascular area almost all over the peripheral retina, and I thought that this was a fever case. And since it was a bilateral case, and after completing the PRP laser, I just put air in the eye, and this was the end of the surgery. And this was just 3 weeks post-op. The intraocular pressure was normal, and corneal diameter was a bit less, and he could follow and fix, as you can see, the light and iPhone. So I decided to operate the fellow eye 3 weeks later, and it did almost the same way, and even the retina was a bit better than the fellow eye, although this eye was the larger one. So in such eyes, I just want to emphasize that in such eyes, the back of the eye may not be so bad as it looks from the outside. So we should give a chance for such eyes, I think. So anybody want to comment?
Love that surgery. I could never imagine. So it was you were expecting that posterior pole? I mean, even in fever, you have tractions, you have just fibrosis in one side, but all the eye was, like the hyaloid was...
contracted.
Yes.
Actually,
so,
I'm not so
like
sure about
inflammatory
the
thing,
diagnosis, but since there was a large area of peripheral avascular retina, that's why I thought of fever. I don't think it's unusual, completely.
I would think, Dr. Yarnakawa, please.
No, that was a beautiful case. Thanks for showing that. I think in this case, you had two really bad eyes, and so I think there's nothing to lose to operate. If it was unilateral, I think observation is an option. But if it's both eyes, I think there's very little to lose. So I would have approached it similarly too, with reforming the anterior chamber first, removing the iris and lens. And if the cornea is opaque, sometimes, and there's no view to the back, sometimes you can just do that part and stage it, come back like a month later to wait for the cornea to clear after you separate it from the all the adhesions, and you do a stage procedure too. I'm not sure what the diagnosis is either. It looks very atypical for fever, but it's certainly a consideration. Might have been like an infectious process potentially. I'm not sure, but a very cool case.
I was just thinking, if you were thinking infectious, though, posteriorly, it did not seem, there's no pigment, there's no other signs of that there had been some disruption from some, if you're thinking like a viral or toxoplasmosis kind of source, that they obviously can cause the membranes in the vitreous to become thick like that, but I would also expect the retina to be much more involved. So, and avascular-wise, again, with congenital infections, you can see that, but I would expect a little more sign from the retina.
And the perfect segue to the next case.
The next case. Okay, this is mine.
No,
Again.
she just had a question beyond.
Oh, please.
Oh.
Last case. I don't know. Yeah. Okay, now it's working. Nicola Ghazi from Cleveland Clinic, Abu Dhabi. I wonder whether the hemorrhages were present before the surgery or not, because you could see some bleeders from the edge of the iris as you were doing the dissection. But if they were present before, and with this paramacular fold that I could see, I mean, shaken baby syndrome could be also one of the diagnoses. Patient with bilateral glaucoma needing frequent eye drops, etc. I don't know if this could help you in figuring out the diagnosis of this patient.
Thank you, Nicola. Actually, these hemorrhages were present before because I have done the ultrasonography and I have seen the vitreous opacities probably representing those hemorrhages. And for shaken baby, we are not expecting peripheral avascular areas so widely distributed. So that may be an option, maybe. But I think fever may be a bit in the beginning of the list of differential diagnosis list. So my second case is a congenital toxoplasmosis case, but he was also born preterm, 32 weeks and 1,600 grams. And he had some intubation in NICU, and he had intracranial hemorrhage associated, and he had congenital toxoplasmosis, and he is under systemic treatment. And one eye was buphthalmic, and the fellow eye was microphthalmic, very microphthalmic. And in this eye, you see posterior synechia. The lens was a bit cloudy, and as you see here, retina was detached, and retina was freely mobile. So that means that you have a retinal break, and you have a ridge there. So I was really afraid of the case at the beginning, because when you have ROP associated with a retinal break, starting from the beginning, so you have under zero. So I caused another break in the ridge area, since it was very freely mobile, and since I have a posterior break, I couldn't put PFCL at the beginning. Then I had to put PFCL. That triangular shaped retinal break was at the beginning. You see this. I tried to release tractions at least in that retinal break area. As you see here, there was toxoplasmosis scarring there. And under PFCL, I could do some posterior hyaloid removal. And as you see here, I could release the retina, at least from the retinal break area. And this is the iatrogenic one at the ridge. And we could do the laser to the peripheral vascular area and put only gas. C3F8 gas for this case, since it was an inferior retinal break, I didn't want to put SF6, and this is the post-op view of the case. The fellow eye is very microphthalmic, and this eye has substria, as you see here, because of the buphthalmos. And this is the post-op view of the eye. So retina was attached. Actually, this was a surprise for me because I was afraid of, having a recurrent retinal detachment for such case. But in cases, when you can release at least from you may not remove the whole vitreous or the whole posterior hyaloid, but in the retinal break area, if you are sure that you release all the tractions, it may end up with this.
I think we've had a nice show, yeah. For two cases now where we would normally say uncurable, we have attached retinas, so...
I just want to emphasize one more thing. I have one more case like this, not with retinal break, but preterm baby, but it was 35 weeks or something, but with congenital toxoplasmosis, but ROP was very severe. So the inflammation may cause ROP to be more severe, I think.
Thank you.
So I'm just going to begin here. So I have a case of acute retinal necrosis, and I have some introductory slides and PFO. So we will just review the case, 42-year-old Caucasian female. We'll just kind of go through. You see her vision was pretty good. Pressures were a little high, and then the anterior chamber showed some inflammation, and here was the back of the eye. And so we see this, and most of us are worried about acute retinal necrosis. She was PCR positive for VZV, and you can see it very quickly progressed despite doing intravitreal injections of foscarnet, encyclovir, and Valtrex. At the time, I was only using 1 gram 3 times a day. And so we thought we had it under control, but at that last slide, you could see inferior temporally tractional band. And 3 days later, she completely detached. And so I did the vitrectomy here, and I'm peeling. I couldn't tell if it was hyaloid that was adherent or if they were fibrous membranes from the acute retinal necrosis and the inflammation. And some people with acute retinal necrosis, they don't know how extensive to go with peeling because the retina is so darn thin. And I try to get out still as much as possible before I go and cut the retina, even though obviously a lot of the retina has been damaged. Just because I worry you can make more breaks. Also, people question whether or not to do PFO and acute retinal necrosis detachments because, again, of thoughts of micro breaks that you can't see that are more posterior that can cause some issues with subretinal PFO, which you'll see afterwards I thought might have been an issue. Thank goodness I was wrong. So visually, post-op day 1, hand motions, then she improves to 2150. I think I'm the best thing since sliced bread with acute retinal necrosis here. And then she has this drop in vision. And then you can go to the next slide. And mysteriously, a PFO bubble appears in the macula. And I was just kicking myself, and I was like, no way, I got all that stuff out. We had a frank discussion because I really, with acute retinal necrosis, did not know what I was going to get with her vision-wise, so I didn't want to take her back unless necessary. But unfortunately, she was noting a change in vision. As you can see here, it becomes thinner and thinner and thinner. And again, it did not obviously look subretinal, but something was going on. And she did notice a change. So we did go back to surgery. So I did go back in, and we removed the oil that was there. And after we did that, you'll see here, it was peeling, just wasn't sure, just trying to get it to move in general. Couldn't get the bubble to move. So I thought, maybe I have to peel. And sorry, I don't know if we can speed this up at all, but at one point, what you're going to see is with a little bit of movement and basically taking Nugent and moving the infusion, I got the ball of PFO to actually move, which made me feel much better. Because again, it did not look subretinal on the OCT. And here's the quote-unquote instant replay. Unfortunately, I don't think it shows up as well. But you can see the little ball kind of swirl around, and then, thank you, out of the macula. No, actually, I took the infusion, and I had the infusion. I was playing with the infusion, and then I used a soft tip to remove it, and then peeled the membrane. I'm not sure where it came from or how it was sequestered, and it was how it had formed. And then again, did more extensive peeling just to make sure there was nothing else that was hiding underneath. So again, the take-home points, for acute retinal necrosis, for the detachments, I still will use the PFO. I think, again, personally, I am the kind of person who will try to peel as much as possible, even if I think at the end of the day I'm going to have to cut some retina just to get some better stabilization. And I don't know if we have any time for this, so we'll let Dr. Wolf take over from here.
I think we have had an excellent panel this morning, and unfortunately, we have reached the end of our time. I would like to thank everyone for coming to this early meeting, and I would especially like to thank our panel who has traveled from both relatively near and quite far for sharing their expertise with us. Thank you.